Hello, everybody. My name is Ben Smith. I'm a second year medical student here at the University of Louisville School of Medicine, where I'm also a member of the Distinction in Global and Public Health track. I'm glad to be here today to tell you about a systematic review concerning wastewater based epidemiology that myself and a wonderful group of co authors has been working on. I gained a passion for global health when I served as a Peace Corps health volunteer in Dodoma, Tanzania. Mambo VP to any Swahili speakers present today. That's enough about me, though. Let's get on to the presentation. The name of our paper is Multi-pathogen Sanitation System Surveillance in Low and Middle Income Countries, a Systematic Review and Meta-Analysis. Yes, I know, a mouthful. Also on this slide are my wonderful co-authors and all of our affiliations. Here is the outline for this presentation. We will begin with an introduction where we will talk a little bit about wastewater-based epidemiology in the setting of low and middle income countries. Then we will discuss how we are carrying out our systematic review. Following methods, we will discuss the current stage of our review and what work still needs to be completed, as well as implications for future research. Finally, we'll end with a few limitations and lessons learned. Here's a quick overview of some applications of wastewater-based epidemiology. Note its use in estimating disease prevalence. This is one of the reasons it has seen increased utilization since the start of the COVID-19 pandemic, as well as the fact that it could supplement clinical data to aid in outbreak response or even just baseline monitoring. Who knew poop could be such a powerful tool? There's a big focus on the use of wastewater-based epidemiology in high-income countries, which predominantly use piped sanitation systems. This brings us to the purpose of our research. Our research question is, what pathogens have been detected in pooled community fecal samples in low and middle income countries? Pooled community samples being samples from sanitation systems like piped sewers, septic tanks, pit latrines, and others. But what is the point of all this? Why do we care about the low and middle income setting? Because sanitation systems and wastewater-based epidemiology methods vary depending on a country's economic status. Non-sewered sanitation systems are far more common than sewered systems in low and middle income countries. Looking at this figure, you can think of the left, wet systems, as high income setting, and the right, dry systems, as low and middle income. Also, we care because there is less literature on wastewater-based epidemiology sampling in low and middle income countries compared to the high income countries. And I illustrate some of these differences in the following slides. Here's the toilet in my bathroom at my current residence. And here are a couple of pit latrines that were at the house I lived in Tanzania. Next, here are some photos of wastewater work being carried out here in Louisville, Kentucky, and in Mzuzu, Malawi. Note the technology used by the worker in Louisville to collect samples, and then compare that to the state-of-the-art Nalgene on a stick being used to collect samples in Malawi. There are other differences to think about too. Vaccination and testing may not be readily available in lower income settings, and even outside the COVID-19 scenario that dominates most conversations today, let's not forget that there are some pathogens, like cholera, polio, and measles, that still disproportionately affect lower income countries. We believe these circumstances call for greater focus on wastewater-based epidemiology in low and middle income countries. To determine the economic status of countries in the publications included in our review, we referred to the World Bank, which uses gross national income per capita parameters to classify a country's economy. Now let's move on to methods. First, I'd like to mention that our review is registered in Prospero, which is a registration database specifically for systematic reviews. Its purpose is to increase transparency in the scientific research community and it allows reviewers to check if someone is already carrying out a review similar to theirs, which may aid in minimizing research waste. You can follow this link to visit our registration page, which lays out the current status of our review and parts of our protocol. Now, you may be wondering where we searched for papers. Simply put, we searched PubMed, Google Scholar, and the Sustainable Sanitation Alliance, or SUSANA for short, which is a site focused on, you guessed it, sanitation, especially in low and middle income countries. These are the systematic search queries used to search PubMed and Google Scholar. We first formulated the PubMed query by splitting our research question into 3 key sections: low and middle income countries, wastewater-based epidemiology and/or sampling, and pathogen detection. Then, we referred to PubMed's mesh term database to find mesh terms relevant to these categories. With the addition of synonyms to these terms and other keywords found in pertinent publications, we constructed the search query shown, incorporating Boolean operators and truncation. We then translated this query to a version suitable for Google Scholar's search function. You may note the Google Scholar query is much shorter, and this is due to a search character limit and is also noted later in our limitations. After limiting our search to publications in English and between the years 2000 and 2021, we obtained 1,369 results from PubMed and 12,400 results from Google Scholar. Let me tell you why that is a yikes. There are a number of hurdles when using Google Scholar as a database for a systematic review. First, the character limit of 256 makes it difficult to narrow down your number of search results. Second, the search results cannot be exported in bulk. To circumvent this particular issue, we turned to the Publish-Repair Citation Manager, which had a unique feature of being able to perform a Google Scholar search and download the first 998 results of said search in bulk within the application. With Google Scholar search results being sorted by relevance, we found this to be an appropriate remedy to the presented issues. After finalizing our search results, we were ready to begin screening. We carried out the screening process using a fantastic web tool called Rayan, pictured here. Rayan allows you to import your search results, easily view title and abstract, and record inclusion and exclusion decisions all in one location. You can share your decisions with your co-reviewer as well, which simplifies the process of resolving disagreements for inclusion and exclusion of publications. This greatly reduces the time spent on the screening process, and I highly recommend it to anyone carrying out a review of any sort. We deduplicated our search results from PubMed and Google Scholar separately, and then again after combining those 2 deduplicated lists. This gave us a grand total of 2,260 publications to be screened. Here are our inclusion and exclusion criteria. To break it down simply, we wanted studies from low and middle income countries, not high income countries. And we wanted studies with data that public health officials would potentially use, as the aim of our review is to promote the use of wastewater-based epidemiology in low-resource settings. A unique extra step in our systematic review is the implementation of Beal's list as part of our exclusion criteria. We expect to find potentially predatory journals or publishers in our search results, especially with the use of Google Scholar as one of our databases. Therefore, we are checking Beal's list for the presence of any studies included in our systematic review. Any studies present will be excluded from our review. The third database used, SUSANA, was searched and screened using separate methods due to a lack of systematic searching capabilities compared to PubMed and Google Scholar. On their website, you can visit the Knowledge Hub and view all the publications present. We use the 2 highlighted links. First, the Visit the Library link had a list of 4,234 publications, which was narrowed down to 15 after filtering. The second, the Susanna Publications link, contained 110. These 125 search results were screened for inclusion in our review. Here are the first pass screening results so far. Keep in mind, these totals may change following co-author screening and full-text screening. From PubMed, we have included 99 publications. From Susanna, 0 studies met inclusion criteria, and Google Scholar screening has yet to begin. Also, an extra source we are using will come from publications that did not meet our inclusion criteria, such as systematic reviews. Now I'd like to mention the risk of bias assessment. These are important to ensure the inclusion of quality publications in a systematic review. For the most part, pre-existing assessments exist for those in clinically oriented systematic reviews, not so much for those concerning environmental public health involving fieldwork. For this reason, we produced a novel risk of bias assessment for our review, deriving our categories of bias from Frampton et al. And modifying 2 existing reviews. Here is the product of our efforts. The top 2 questions concern generalizing results to other situations, while the remaining 8 concern, as my mentor Dr. Hodge likes to say, how well the researchers followed their own rules. Questions are answered with a yes or no, and the following classifications are made for publications based on the score received. 6 to 10 yes answers deem a paper as having low risk of bias. 1 to 5 yes answers deem a paper as having moderate risk of bias. And 0 yes answers means a paper has a high risk of bias, which will result in exclusion of the paper from our systematic review. Moving on, the following table shows variables for which data is to be extracted once we have our final list of included publications. Some variables of note are sampling area. For example, if samples were collected in a single town in one state or territory, or perhaps 2 towns in 2 different territories, or even multiple countries. This may help us determine the scope of surveillance that is already achievable in certain places. Another might be units of measurement, referring to the units used to report the amount of pathogen detected in water samples. This is important because there is currently no standard unit of measurement being used to report pathogen prevalence data, which leaves an opportunity for the improvement of scientific communication. We believe we will find evidence to support this need. Now that you have seen our methods, here's our glorified to-do list. We are currently hard at work on the first pass Google Scholar screen, and once that is completed, and Stephen, my co-reviewer, and I have resolved any disagreements, we will be able to move on to the full text screen. With a final list of included publications, we will extract data and then carry out data analysis. An important analysis is on pathogens investigated. Once we know which pathogens have been detected and their prevalence, we will tabulate the disability-adjusted life years for each pathogen on the list. Then we will rank the pathogens by disability-adjusted life years and use the list as a proposal for pathogens that could be prioritized for baseline monitoring in low and middle income countries to improve community health. This is imperative, as we suspect our results will promote the need to focus research, methods, and funding on pathogens that are clearly having a negative impact on people's lives. We plan to do the same with vaccination rates, providing evidence for the need of continued vaccination campaigns in low and middle income countries. Finally, our results will support a real-world pandemic prevention baseline monitoring laboratory in Malawi. In the past, wastewater samples from Malawi had to be sent out of the country for analysis, but they now have a lab of their own. Very exciting stuff. And that just about wraps it up for us. Here are my references, and thank you for tuning in. If you'd like more information, please contact myself or Dr. Rochelle Home.